Thank you for the introduction. You have seen now a lot of tiny lesions, and the pectoralis major tears are relatively large, and as said, they are relatively rare. So I had to look in my database about 10 years back with full text search, and I found less than 10 cases. But nevertheless, I would like to demonstrate you, and I like to familiarize you with the MR imaging in this diagnosis. Admittedly, ultrasound would be an option as well. Clinically, it's a relatively clear diagnosis, as you see here. These are patients with a lot of muscles, and you see the defect of the pectoralis major. Anatomically, this is described usually by two parts, the clavicular part coming from the cranial aspect, and the sternal part from the sternum, occasionally with an abdominal part as well. It inserts about 10 centimeters below the center of the humeral head, and that is one of the reasons that on common MR images it's not within your field of view. I would like to demonstrate you a case which I've shown at this meeting at the ESSR in Vienna. It demonstrates also the difficulties with this diagnosis. 39-year-old male, wrestling, this is a classical patient history, clinical suspicion of partial tear of the long biceps tendon. So the patient is not coming in all cases with the diagnosis as shown before. And you see this is the standard MRs in a proton density coronal view. We're going from the anterior aspect, and you see there are some similar changes in the subdeltoid bursa, and then we move on. It's not quite obvious the diagnosis on these images, then the axial views, and from the cranial aspect we are going down. And you see here is the long biceps tendon, and now you see here some increased signal in this position, which indicates a tear of the pectoralis major as on these images. On sagittal images it is visible, but you will see that it's in here in the more anterior aspect. Here's also a marker which demonstrates you the site of the tear. The diagnosis I have asked with all the differential diagnoses, but finally it was pectoralis major tendon rupture. Clinically, already said, these are patients with weight training, weightlifting or wrestling. The patients, they tell you that they hear when it is torn and out it will pop, immediate pain and weakness. Surgery is considered basically also per cosmetic reason, as you see here. And it's typically they are males and younger males. We have two types of tears. We have the tears which are complete, and they often occur distally at the insertion or at the myotendinous junction. And we have incomplete tears. These are more muscle sprains which are more proximally located and are less important. More recently, research has been performed at the insertion, and it's a nice paper in Skeletal Radiology, and they have emphasized the two layers, the anterior layer from the clavicular head in the anterior aspect, and the posterior layer from the sternal head fibers. And you see, based on this concept, the tear can be in the posterior layer or in the anterior layer. It can be completely torn or incompletely torn. This can be seen, but I'm not sure if it can be seen on MR images. What I have seen, I could not do. It's possible that with ultrasound, with the high resolution, that can work. I come back to the anatomy. We have this clavicular part, the sternal part, and I would like to demonstrate you even the normal anatomy. This is a technician from our institution with an appropriate field of view, but you will see how difficult it is to see the tendon itself. You see the deltoid muscle, occasionally you see the cephalic vein, which separates the pectoralis major muscle and this side. And you see here the long biceps tendon, and we see the tendon structure coming down just to the insertion site, and here is the insertion. The insertion site has a craniocaudal distance about 5 centimeters, and it's very difficult to discriminate is that the clavicular part or the sternal part when we are going down. And definitely the best side of the insertion is where the so-called quadrilateral space is present. The axillary veins are behind and here you see the insertion site. But you see this is quite far away from the normal field of view you have on your standard shoulder protocols, and that makes the difficulties with this diagnosis, I believe. This is the T1 weighted. We can go through these images more quickly, but you see again the insertion site with the pectoralis major, and here you see the quadrilateral space at this site. So pectoralis major muscle, pectoralis minor, short biceps muscle, quadrilateral space. This is the focus on these sites. Of course, we would like to see the tear also from in corneal view and corneal sequences. The problem is that our standard corneal oblique imaging planes are not in this way. You see here, this is the tendon and this is the direction of the insertion. So if you plan to demonstrate that in a corneal oblique view, you have to adapt the corneal oblique view in more anteriorly projected, as you see here, in this way. And then I'm coming back to this normal volunteer, and you see here the tendons, but it still remains difficult to see the insertion site at this projection. Thus, it remains important to make the diagnosis on axial views. And this is the same patient I have shown you before. He underwent a reattachment, pectoralis major tendon, and then he had another accident, a fall, and he had the same symptoms. But now you can hopefully then see the lesion quite easily. You see here it's starting with increased signal and we are going down, and there is no doubt that the pectoralis major tendon is torn again. You see on this image the field of view was larger, it was easier to make the diagnosis. The corneal view was still not that perfect, as you see here. Yes, there are some signal changes around here, and then we are coming back. You see the postoperative findings at the humerus, but the tear itself remains very difficult to see. And you see the corneal imaging plane was performed in this way, also not perfectly for this purpose of diagnosis. So with that, I would like to demonstrate two further cases only to familiarize you with this diagnosis. This is from Radiopedia. You see here the tear, and we can follow here as, when we are going down on this side. This is the corneal view. And these are now further cases I would like to demonstrate. So an older case, 47-year-old male, gymnastic injury at the high bar, and the diagnosis was hematoma, but not a tear in the initial report, but you will see it's far more than only hematoma. Here it was a full tear, and this was also the clinical finding of the pectoralis major and this on these patients. And here this is the corneal view. Only to demonstrate you how difficult it is, this is on the sagittal view, and you see that here again when we are coming down to the insertion site at the humerus. Usually we perform MR arthrography, and that's the focus. You have seen all the tiny lesions, and this is another case where the initial diagnosis of pectoralis major tear was completely missed. Although it is visible, you see some changes in the subacromial space, but now you see here the increased signal in the sagittal, on the sagittal images, and that here, this is not a tear, this is some fluid which has projected outside in the subscapularis muscle. And if you have problems, and if you don't have a T2 weighted sequence, you can reconstruct it even from the sagittal image, and this I have done here, and you see here the tear as well. So this may sometimes help if you don't have T2 weighted images in the appropriate imaging plane. So the take-home message from this short presentation is use. If you suspect a pectoralis major tendon tear, a larger field of view, medial-lateral has to cover the midline chest, superior-inferior has to cover down to the mid of the humeral shaft, And the corneal plane, if you think about that, it should be anterior oblique and not posterior oblique perpendicular to the glenoid as usually done for shoulder imaging. And finally, think about it is a clinical diagnosis which demonstrates you nicely on this video, which has been also published in the book made. So it's obvious. I thank you for attention.